afternoon, everybody, and I'd like to thank the organisers for inviting me to speak today, and I'd like to thank you for still being here and not having been tempted by any shopping down Oxford Street. So my talk title is The Effects of Bariatric Surgery in People with Obesity. Notice I've switched it, so we should be using patient-first language. And the provocative question is type 2 diabetes curable? Here are my disclosures. So let's just start off with the definition of what do I mean by curable of diabetes. So there are two definitions: partial, which is an HbA1c of less than 6.5, and this was the level that Mike Lean this morning was talking about with the direct study. So he was talking about partial remission, not necessarily complete. So complete remission is an HbA1c of less than 6 off all medication for at least 12 months. And for prolonged remission, we're looking at people who have an HbA1c of less than 6 for 5 years. Now, I'm going to start off with a typical patient who I see. This is Mr. JW. He's 45 years old, and he has a BMI of 50, and he has type 2 diabetes, which is poorly controlled. He also has fatty liver disease, hypertension, obstructive sleep apnea. He hurt his knee, so he can't exercise anymore. And actually, for him, life is pretty miserable. He's tried lots of diets before, and previously lost weight, and put it back on. This is Mr. JW, 2 years after a gastric bypass surgery. So he's lost 54.5 kilos. He now no longer has type 2 diabetes. He's in complete remission. He doesn't need his CPAP machine anymore, having been tested to make sure he doesn't still have OSA. No longer needs his blood pressure meds, and actually, for him, life is looking a lot better. Now, I want to divert a little bit to obesity, because there's been lots of talk today about diabetes, but not very much about obesity and why this is such a problem in our current environment. So obesity impacts upon every single system in the body. In particular, the metabolic complications are causing the greatest morbidity. Cardiovascular disease, cancers, type 2 diabetes, fatty liver being the greatest of these. Then there are also the mechanical effects of carrying around excess weight. So obstructive sleep apnea, joint problems, urinary incontinence. And there are also the psychological issues. A lot of patients with severe obesity have depression, anxiety, and whether one causes the other or the other way around, we're not entirely certain. But most important of all is that severe obesity reduces life expectancy. A person with a BMI of 50 only has a 50% chance of reaching the age of 70. So for most people, it's reducing their life expectancy by at least 10 years, and also the quality of their life for their remaining years when they are alive. We know that as BMI increases, then the risk of type 2 diabetes increases. If we look at the UK population, probably 90% of your patients with type 2 diabetes are overweight or have obesity. And why is that? Well, it's complicated, but excess adipose tissue releases a panoply of different cytokines which cause systemic inflammation and insulin resistance. So we have the pre-diabetic stage, which we've talked about a bit earlier, metabolic syndrome, and then we have type 2 diabetes, NAFLD-NASH, and then also cardiovascular disease. And we now know that obesity is an independent risk factor for cardiovascular disease, independently of the metabolic complications that we can typically identify. So the good news, we all know this, weight loss improves all of the complications of obesity. And as we saw earlier from Mike, we can achieve this. But depending on your starting point, the amount of weight that you need to lose to impact upon your type 2 diabetes or your obstructive sleep apnea is greater. So again, this morning, Mike was showing you people who lose 15% of their body weight are the people who manage to have remission of their type 2 diabetes. Now, that is exceptionally difficult with lifestyle measures. So we have fantastic, nice guidelines for how we actually should assess and manage people with obesity. These are going to be updated next year, but these are the ones from 2014. And actually, weight loss isn't the problem. These are a series of studies using various different diets that show that patients can lose weight. Patients who come to see me have usually lost my body weight in total from previous diets several times over. They've lost the weight. They've been really happy, life has been better, they've got a tattoo, new clothes, but what happens is they put the weight back on. And we know that 95% of people who lose weight will put it back on over a 4 to 7 year period. So yes, the very low calorie diet works. Question is, where will it be at in 5 years' time? And why is that? Well, the reason for that is how body weight is regulated. So during evolution, ensuring that you ate when food was available was fairly critical. So we have lots of systems to make us eat. And a lot of these are at the unconscious level, so at the level of the hypothalamus or the brainstem. So your brain receives signals from your gut, your pancreas, and your adipose tissue to inform it about how much food you've got stored and what you've just eaten for lunch. And that's set up to make you eat, not to stop you eating. Now, in our current environment, we don't eat because we're hungry. How many of you just ate a mince pie or had the sort of the caramel chocolate sweet that was up there? Did you need it? No, you didn't need it at all. You've just eaten an extra 300 calories that you really didn't need. Why? You did it because it looked good, you're at a meeting, it's there, it's free, and everybody else is doing it. So in our current environment, we eat because of the environment. We eat because it was rewarding. The caramel and chocolate together has this really lovely, palatable part to it that makes you put it in your mouth and you want more of it. Whether you did or didn't choose to have any dessert, sort of sweet offering depends on your genetics. So your genetics determine whether when you see something sweet, whether your brain is driven to eat it or not. This is a study that came out from Sadaf Faruqi's group in Cambridge this year, and they looked at people who were constitutionally thin. So people who always claim themselves, well, I've got better willpower, I just don't choose the cakes. Well, actually, when they looked at the genetics of thin people, then they have genes that help them to stay like that. So actually, genes that sort of help you to be leaner, slightly increased energy expenditure. And if you compare that to people with obesity, then actually they have more of the changes in genes that predispose you to actually eat food if it's available. So actually, it's the underlying genetics interacting with the environment that's important. So over the last 30 years, we've begun to understand that the gut isn't just a nutrient tube where digestion happens. It's basically the largest endocrine organ in the body. So from the moment you put food in your mouth, right through to your rectum, there are a whole panoply of endocrine cells that release hormones which control appetite and blood glucose. And this is why most of the drugs in development or becoming available for treating obesity and type 2 diabetes are focused on gut hormones. So for example, GLP-1 is a gut hormone that's released normally when you eat. So again, just to come back to the genes and environment mismatch, because people say, well, how can it be genes if obesity's only gone up so much in the last 20 years? It's the combination of the two. So we've evolved in a system where if food is available, then we will eat it. And as more food becomes available, then more of the population become overweight. Now, the problem is that during the course of evolution, a famine represented a major challenge or threat to survival. So we have developed really strong biological systems to defend against a famine. Now, a diet is the modern-day equivalent of a famine. So if you go on a diet, you're restricting your caloric intake down to 600 calories a day. To all intents and purposes, your body thinks you're in a famine. Why wouldn't it? And that's what happens, that we then invoke a lot of strong biology that causes weight regain. So as soon as a person goes on a diet, then there's a change in the hormones that come from the gut that then stimulate appetite. There's a hunger hormone that comes from the stomach called ghrelin, And as soon as you start to lose weight, even 1 or 2 kilos, we know that levels of this hunger hormone go up, and they act on the reward part of your brain and the homeostatic part of your brain. And also the hormones that normally tell your brain that you've eaten, they go down. To make matters worse, your energy expenditure goes down because your body wants to conserve energy. So all of these things mean that as soon as you start to lose weight, then you get an increase in hunger, decrease in energy expenditure. And when we use functional brain imaging to look at the brain's response to food, then the brain response to food completely changes in all the areas of the brain that we know are linked with addiction and also incentive motivation. So what happens? The person puts the weight back on. You can manage to do this, or some patients can manage to do it for longer, but it's like holding one of those really elastic exercise bands. You can do it for a while, but if there's any other stress or anything else in your life that comes along, then patients will put the weight back on without intensive support or something else to help them. So this is why obesity is now recognised by many professional bodies as a disease, because of the changes in the biology and the genetics that drive it. And earlier this year, on the 3rd of January, the Royal College of Physicians also called for our government to recognise that obesity is a disease. And actually, part of the reason for doing that is to actually move it away from just being a lifestyle choice. And there are huge health inequalities with obesity, in particular in children. And you have to remember that 1 in 3 11-year-old children currently has obesity. Not overweight, currently has obesity. The levels are higher in the UK than in the US. So the problem with obesity and type 2 diabetes in adolescents is a real one. So now I'm going to switch to bariatric surgery. So why bariatric surgery? I'm a physician, not a surgeon. I line manage my surgeons, but I'm not a surgeon. Why bariatric surgery? Well, we know that bariatric surgery engenders sustained marked weight loss out to 20 years. And if we come back to Mr. JW, it also causes remission of type 2 diabetes. What about adolescents? So again, we undertake bariatric surgery in adolescents. This is a study published in the New England Journal of Medicine from the States. Again, a mean BMI of 53, 95% remission of type 2 diabetes in these young people with improved quality of life. But the effect on diabetes is not new. If we go back to the 1950s, when people had gastrectomies for peptic ulcer disease, again, it was noted that patients with diabetes, it remitted almost immediately after the surgery. So my patients who have surgery today, an operation that takes 90 minutes, they go home tomorrow, then the vast majority of them, even if they're on insulin, will stop all of their diabetes medication as they come into hospital, and then they go home off their medication. So it's an immediate effect on the diabetes. And again, 1995, another paper, who would have thought it? Operation is the most effective treatment for adult onset type 2 diabetes. So how does it work? Most people, when they think about bariatric surgery, think about gastric banding. Now, again, a lot of centres, I'm based at UCLH, we don't undertake gastric banding. It represents less than 5% of all operations done outside of the private sector. And the reason for that is that it doesn't change the gut hormones. Sleeve gastrectomy and gastric bypass change all of those hormones that come from the gut that regulate appetite and blood glucose. And that's how it works. What happens is it reroutes how nutrients stimulate the hormone-producing cells to change the actual levels in the blood from immediately after surgery. So we get a change in all the hormones that regulate glucose and regulate appetite. So the two operations here, gastric bypass, these are both laparoscopic. And as I've said already, they take about 90 minutes. So with a gastric bypass, there's a small pouch of stomach, and then the jejunum is joined onto the gastric pouch. And then with a sleeve gastrectomy, which is the more common operation at the moment, it involves removing 90% of the stomach. And I've said already, they work by altering blood glucose and appetite. So the simplistic view is that we're changing all of the signaling that comes from the gut that acts on your pancreas and your brain. Clearly, it's a little bit more complicated than that, because when we change the gut, we change a whole host of other things. Vagal signaling, microbiome, bile acids, etc. So it's a combination of these. But the change in gut hormones, we know from lots of different experiments, is a key driver as to why these surgeries work. Well, what about the risk? What's the risk of these surgeries? So if we look at various operations in patients with obesity and type 2 diabetes, down the bottom of here are the bariatric surgery procedures. So in most centres in the UK, the risk of dying is less than 1 in 1,000 per operation. And given that the vast majority of patients who I see have already got very complex comorbidities by the time they're referred. So it's a relatively low risk operation if you have it in the right centre. There's a trend in the UK for lots of patients to go to Turkey or to other Eastern European countries on a package deal to have their bariatric surgery done because they're finding it tricky to access in the UK. And there are lots of problems with those patients then coming back straight to ITU from Heathrow. So if it's not done in the right environs, then it's a problem. There are nutritional deficiencies. By rerouting the gut, we do change how nutrients are absorbed. So iron deficiency, vitamin D, calcium, and B12. So these patients need lifelong monitoring in terms of their vitamins. And Carly Hughes, who's very active within the Royal College of GPs, has written a guidance for GPs for patients who've had bariatric surgery, and it's called 10 Top Tips. So there is some good guidance out there, and also on the BOMS website for what needs to be measured. So why bariatric surgery apart from the weight loss? Well, in addition to improvement in diabetes, which I'm going to come back to, it also impacts on all of the complications that come with obesity, cancer. It prevents incident type 2 diabetes, stroke, and ischemic heart disease, and overall a 40% decrease in mortality. And if we look at the latest studies, this was published this year in JAMA, showing you a reduction in MACE events using a primary composite outcome from all-cause mortality, coronary events, cardiovascular events, heart failure, nephropathy, and atrial fibrillation. Now, obviously, these studies are not randomised. They are prospective match studies, so they're not ideal. But if we look at all of the different outcomes, then the bariatric surgery group has a marked reduction in all-cause mortality, heart failure, coronary artery disease, cerebrovascular disease, nephropathy, and atrial fibrillation. So we haven't seen this with any other lifestyle measures to reduce obesity. What about cancer? Again, if we look at the hormone-responsive cancers, then again we see a reduction in all of these, in particular postmenopausal breast cancer in women is markedly reduced after bariatric surgery. So now I'm going to finish off by coming back to diabetes. So this is a randomised controlled trial done at the Cleveland Clinic comparing patients who were randomised to either best medical management for their diabetes, sleeve or bypass. And they were poorly controlled, their diabetes was poorly controlled, as you can see, with an HbA1c of over 9 at the outset. This is what happened over 5 years. So on the left-hand side is BMI, and on the right-hand side is HbA1c. So the medical group, in terms of no change, 71%, improved 13%, versus the surgical group with a 57% improvement in their diabetes. What about medication? So insulin here is green, blue is no medication. So 5 years after surgery, 45% of these patients are not on any medication with an HbA1c of less than 6. Sleeve gastrectomy is not quite as good as bypass, but this isn't significant at this time point. There have been 11 RCTs comparing best medical treatment, including GLP-1 agonists, versus surgery. All of them favour surgery in terms of HbA1c control. And what about the durability? Again, if we get out to 12 years after surgery, still 50% of patients are not taking any medication. Now, how long you've had the diabetes for matters. So in Mike's study this morning, they excluded anybody who'd had diabetes for more than 6 years to recruit them into the direct study. The longer the patient had diabetes, the less likely they are to have remission. And again, this is a new study that's come out showing, again, remission at 2 and 5 years. So the longer the patient has had diabetes, the less likely they are to have diabetes remission. And that's because diabetes, like obesity, is a chronic progressive disease. And if your beta cells are already worn out, then actually, over time, then the beta cells are going to fail. So in terms of comparing the RCTs, all of them show better weight loss, which has other benefits, better glucose control, high diabetes remission rates, and a lower burden of drugs, in particular insulin, which has a marked impact on patient quality of life. But timing as to when the surgery happens is crucial. So back in 2014, NICE basically said that for a patient with a BMI over 35 with type 2 diabetes of less than 10 years, they should have an expedited referral to be assessed for bariatric surgery. There's quality standard that goes with this as well. And also for patients with a BMI of 30 to 35, again, they could be referred to be considered. And if a person was of Asian origin, we can drop the BMI point by 2.5. There are also global guidelines which echo the same, showing that patients should be referred for assessment to see if they want it. Diabetes UK, again, echoing this in 2016. Currently, less than 1% of patients are referred to even see whether they're interested in having bariatric surgery. So there's a kind of a bit of a disconnect between the evidence and what happens. So take-home messages. Bariatric surgery at the moment for people with a BMI over 35 is the most effective treatment for people with diabetes in terms of weight loss, diabetes, but the timing is critical in terms of not waiting until it's too late. But it's a progressive disease, and actually going forward, we need to have surgery and medication. We need to look at the benefits of the two, not say, well, bariatric surgery or intensive medication. It needs to be both if we're going to reduce the cardiovascular deaths that are still the biggest cause of death in people with type 2 diabetes. I think we need to move away from cure, because I actually think saying that somebody's cured is dangerous and then they may not go back for future treatment. We actually need to look at remission, improving control, because that's what we need in terms of a long-term condition. I'd like to acknowledgements and thank you for your attention.